All right, so this is our next talk. This is a talk on spine. And I'm going to cover a couple of things. I'm going to cover some miscellaneous congenital stuff. I'm going to cover tumors of the cord, degenerative stuff, post-op stuff, and some demyelinating things as well. So both some cord and some bones talks. Try to hit the high points. So here's our first case, and showing you both axial and sagittal imaging. And the thing that we're looking at is this thing right here, which we can say is sort of fat. So anytime you see that, then you should also be noticing the fact that that cord is way too low, right? So 5, 4, it's like all the way down here basically. So it's a low-lying cord with a fatty mass attached to it. So that's classic for tethered cords. So what do you need to know about tethered cords? Basically, if they're attached or tethered too low, then as the body grows, it ends up stretching the cord, which can cause ischemia and end up, causing bad problems. So the earlier this is identified, the better. That's why they do a bunch of different screening stuff. You may have had to, like in your peds rotation, been subjected to do screening ultrasounds for this, and you may remember who gets screened. Well, it's better. So the one people who get screened, so anal atresia, so like Vactor, if you remember that, that's a big testable thing. I think it talked about the peds talks, but like Vactor, anal atresia, tethered cord. Low-lying cords are also seen more in spina bifida. You may remember they have those gross tufts of hair on their back. And then low dimples below the gluteal crease do not need to be screened. So I think if you're going to remember anything, I would remember that, because basically, if you remember that the people who have low dimples don't need to be screened, everyone else does get screened. So it's easier to write a who doesn't get screened question than a who does get screened question, because everybody else gets screened. If you're going to remember the second fact, I remember the anal atresia Vactor correlation. If you're going to remember a third thing, I remember that picture that I just showed you there that has a fatty mass, because lipomas of the cord are associated with tethering. All right, so next case. Let's get a zoom up here. So that's the thing that we're looking at. So it's sort of an abnormal cystic-looking thing hanging out the terminal bottom part of the cord. So terminal being the terminal ventricle. So once you've seen one of these, then you'll know what it is. So this is a pretty big one, though. They can be smaller than that, but it's a developmental variant, and it's normally a portion that involutes, but it's basically persistent thing. Sometimes, I mean, they're incidental. They're incidental. Just remember that. Just know what it looks like. All right, next case. All right, so we've got 3 different MR sequences here. So let's name these if we can. So CSF is bright, so that's a T2. CSF is dark, so these are T1s. And looks like there's some stuff enhancing here. So this is a post-contrast. Now, how do I know that he's had surgery? What I like to do is I like to look back here. Look at the skin. See that little thing right there? See that? It's like the scar from the incision. So that's, if you don't see an obvious bone, I mean, he has a bone defect here, right? But if sometimes it's not so obvious, you're not sure, you're on the fence, is the guy had surgery or not? Look at the skin. It's pretty hard to get in there and muck around without cutting a hole in the skin. So, and usually it looks like that. So that's like a trick, somewhat practical too. Okay, so the point of this case is to show you. So if you've ever been involved in protocoling for spine MR, you may have noticed that sometimes people get contrast that aren't like, you think, oh, contrast, that's like infection, right? So the other people who get contrast are anybody who's had surgery, especially in the lumbar spine. And this case is the reason why they get this case is the reason they give contrast is because just like in cardiac or SCAR enhances with gadolinium enhances in SCAR later on, it's the same thing with SCAR anywhere. So like recurrent or residual piece of disc doesn't really enhance, but SCAR does. So the difference is that a piece of disc versus is that a piece of SCAR? I give contrast and I can tell that it's SCAR, and that's why I give contrast. So this is a great example of that. So if we look right here, this mess of shit right here is a bunch of SCAR, and it's actually wrapping around that nerve. And now you can see that it's enhancing, right? So boom, all that. So SCAR. As we scroll through here, you can see all the mass effect that it has on the neural foramen, and it's just a really bad case of that, right? Look at that huge big scar. So that's a big problem for this guy's totally screwed. That's why you don't let people work on your back. All right, next case is another post-op case, and I'm deliberately picked one that had all this metal artifacts, so you'd be like, so get in your mind, like when you see post-op spine cases, you need to be thinking about post-op scar like that, or you need to be thinking about this. So obscured. Okay, now look at those nerve roots. Look how thick they are, and now they're sort of displaced peripherally, almost like the sac is empty, right? So that is an empty fecal sac. It's a buzzword. So this is arachnoiditis. You can actually have enhancement of the nerve roots for around 6 weeks post-op. That's considered normal. After that, it's abnormal. It's infectious or inflammatory, like stuff you say in lungs. Could be infectious or inflammatory. So it could be infectious or inflammatory. Useless thing that I'm going to toss in there. And move on to the next case. Infectious or inflammatory, next case. So the way to show this is this empty fecal sac. It's a very classic Aunt Minnie look for arachnoiditis. I think the clumping is harder to show on a single image. If I was going to show it, this is how I would show it. And somebody who's had surgery, you can see this infused and looks abnormal. So there's this entity called failed back surgery syndrome that was developed because most back surgery fails. So early on, the reason that back surgery fails is that it gets infected. Later on, 3 things occur. So recurrent disc, scar, and arachnoiditis. So remember that I said that distinguishing between these 2 characters is the reason you give GAD, and that the scar will enhance and the disc will not. Arachnoiditis is going to be shown. Clumping nerve roots could be the way that it would be shown, but I would bet you that it was more likely to be shown as the empty sac sign. Okay, so I'm going to cover a confusing topic that also lends itself well to multiple choice. Got here is an axial T2 through the lumbar spine, and I just want to point out to you that there's a bunch of different nerves at any different level. So we've got yellow nerves here that they're on their way out, they're exiting. And then we've got these red nerves here that are on their way down to exit out the next level. I call those like descending. And then there's some other nerves too for the different levels as we go. So just watch sort of as I scroll down here and see these yellow ones are on the way out, they're on the way out, on the way out. And then the red ones are going down. Now it's their turn. They're going to start to go out. So next level. So the point of this is to we'll look at it again here. If we've got 2 different disc bulges, protrusions, and we've got one that's the yellow one that's sort of hitting that exiting nerve, and then we've got the red one that is hitting the descending nerve. So this would lend itself well to multiple choice. You also see this in real life too. So they are going to involve different levels, so the symptoms and stuff will match up. So this is how you figure it out. That and understanding it. I'll take a diagram here. I've got a blue box and a green box, and we'll take a blue cut right through this level. So that's a sort of a coronal, and we're going to take this blue box and make an axial. we're going to see that. You can see that there's the yellow nerve that's on the way out, and then the red nerve that's on the way down. And then we'll take another cut at a different level, let's say this level of near the disc. So that's here, this green box, that's different level. So you can see that if you've had disc here and disc there, that the yellow disc is going to be hitting the L5 nerve, and that the red disc is going to be hitting the S1 nerve, and they're at the same level. So, make a great multiple choice question. Is it the L4 nerve? Is it the L5 nerve? Is it the S1 nerve? And then it would have to tell you at what level that you were at here to be able to do that. I think this was never explained to me well when I was a resident. So I found it to be a confusing topic. Probably some of you do too. But no longer, because now I've pulled back the curtain on that. All right, so next. All right, so this is a way that I like to teach spine tumors. It's the idea that there's a snake, which is the cord, and then there's the ball or a rabbit or something, and that's the tumor. So snake, normal-looking ball. So we've got three basic scenarios you can have. You can have your snake in a house with the ball outside of the house. You can have your snake with the ball sort of pushing on him inside the house with the snake, or you can have a hungry snake who's decided to eat the ball, and he looks sort of like that. So 3 different snakes, 3 different scenarios. So the first one, the one that's in the house, this is extradural. So you can think that the ball, the mass is not anywhere near the cord. It's not even pressing on it. And then you could have extramedullary, which means it's not inside the body of the snake, but it's intradural. So it is in close enough proximity that it's pushing on it. And then you have intramedullary, where he swallowed it. So there's a differential for each one. I think that it's really difficult to tell them. Well, some of the things are obvious. So they come in 2 categories. They're like either obviously different within the differential, or they're really, really hard to tell apart. And those are the ones that at the view box, you would just list them in the differential and let the pathologist figure it out. But for the purpose of multiple choice, I'll give you a few extra hints that I think are generalizations, but more than likely they won't list the ones that are very closely that look very similar in the differential. And if you can get this far, you could probably get the question right, or you can at least eliminate answers. But this is where you'll start anytime you're dealing with a mass and next to the cord. Localize it as either ball outside of the house, ball next to the snake, or the snake has eaten the ball. So let's start with extradural. This is basically like disc bulges and mets. Those are the 2 things. There's other stuff, but just remember those 2. For extramedullary intradural, remember sort of nerve-based tumors, so like schwannoma, meningioma, those are the classics. Neurofibroma, that's a classic. And then drop mets, and these are drop mets like medulloblastoma, cord plexus, carcinoma, like these kinds of things that famously do drop mets. Those are the ones that we're talking about, like melanoma can do drop mets, like that kind of stuff too. And then intramedullary is going to be your primary cord tumors. So like astrocytoma, ependymoma, hemangioblastoma, and those 2 of those really look alike. Astrocytomas and ependymomas can really look alike. So let's practice. So we've got this thing, and that sort of looks like the ball is in the house with the snake, and it's pushing on the snake, right? And then this other one here looks like the snake ate the ball, right? Convince you of that? So if you think back to our differential, the ball that's sitting next to the snake, that is extramedullary intradural, so schwannoma, meningioma, neurofibroma, drop mets. Drop mets probably going to be multiple. Schwannomas and mengiomas, I think, are really hard to tell apart. If you're forced to pick without anything else, schwannomas tend to be a little bit more common there, and they will envelop the nerve root. Meningiomas will not. The dural tail, like if you can see a clear connection with the dura, that's a classic finding for meningioma. All right, so now how do you tell apart astrocytomas and ependymomas? I think it's really difficult. This is my recommended strategy. So this is my cord, and the red is sort of cervical, and the orange is lower down like lumbar. You can see like the cauda equina coming out of it. So it's cervical, depends if it's a kid or an adult. If it's a kid, I would call it an astrocytoma. If it's an adult, especially if there's hemorrhage, think about calling it an ependymoma. Now, there's another classic thing that's shown in the lumbar spine, like lower down in the cord, and that's this myxopapillary subtype of ependymoma. You don't need to know anything else about it other than it affects like lower thoracic / lumbar cord. It's a primary. The snake has eaten the ball. It's an intramedullary tumor. Now, hemangioblastoma was the third one that I mentioned. That looks a little bit different. This is a picture that I've shown a couple of times, I think. And the main thing, and in this case, there are multiple. It's all these little things here. And you may remember there's a classic association with this. So 3 letters, 3 words, von Hippel-Lindau, which has pancreatic stuff, abdominal stuff, bilateral renal cell, clear cell subtypes, PHEOs, and then CNS stuff. Remember the endolymph sac tumor, hemangioblastomas in the cerebellum and in the cord. These tend to actually involve the thoracic level the most. Cervical is actually the second most common. And 30% of the time when you see hemangioblastoma in the spine, you should be thinking about VHL. And if with an association that common, it's highly likely to be tested. All right, so moving out of that, on to the next topic here. We've got 2 different MR images here. One that's T1 and one that's T2. I'll take a zoom in here. And you're probably thinking, well, okay, so the marrow is involved and the disc is involved. It could be infection, could be maybe cancer, it's just Mets. I will tell you that metastatic disease to the disc never happens, in quotation marks. This is like, at least for the purpose of multiple choice. So when you see something like this, I want you to look straight at the disc. Now the follow-up question would be, where does osteomyelitis start? So I don't want you to get confused because I told you, like, look at the disc, look at the disc, look at the disc. You see the disc, then you see adjacent end plates, you call it infection if you're forced to choose. But it does not start in the disc. This is an important thing. It actually starts here at the end plate, and then it crosses into the disc, involves the disc, and then breaks through, involves the adjacent end plate. So that's the order that it goes through, and it's like a hematogenous spread. Unless you're getting directly stuck, like you're not stepping on a nail, you're not having a diabetic ulcer in your spine, probably. So it's a hematogenous spread of infection. This is like an IV drug user that's going to be getting something like this. So classically anyway. So remember, it doesn't involve the disc first, but it almost always involves the disc, except when it doesn't. So here's another case, and this is an exception to the rule. Remember, exceptions to rules are highly testable. So this, I'll tell you right now, is it's osteomyelitis that's sparing the disc space. So when I say that, you need to think about TB. And this has all the classic features of TB. We've got, let's take a zoom in here, spread along the anterior vertebral bodies at multiple levels. So that's like a buzzword. Sparing of the discs, buzzword, and these psoas abscesses. Those are all the classic things for TB in the spine. Now the last one that's classic is the so-called gibbous deformity. That's like total destruction of the vertebral body and a focal kyphosis at that level. You can have a focal kyphosis from lots of stuff. So anytime you get absolute destruction, but if you're shown the so-called gibbous deformity, which is like basically somebody totally bent, like the worst focal kyphosis you've ever seen, then you think about TB first for the purpose of multiple choice. Okay, so next case, we've got, let's actually run through these. So T2, we see in the CSF is bright, right? And then the next one, CSF is dark, that's T1, and then we can see that the last one is fat saturated. And why do you do fat saturated T1s? You do it when you're going to give contrast. So got those labeled. And the finding is this right here. Notice the nerve roots have enhanced. They can be from several different things, but I want to emphasize that for the purpose of multiple choice, if you see enhanced nerve roots, you should think about GBS, Guillain-Barré. So if remember from step one, this is like a Campylobacter thing, a weird autoimmune, and the buzzword is like ascending paralysis. So it's like start with your toes, you can't wiggle your toes, and you can't wiggle your knees, and you can't wiggle your hips. It's like headed up. So ascending paralysis, recent infection, Campylobacter, can be from a whole bunch of different stuff, but Campylobacter was the one on step one that they always would ask. Other trivia that's less likely to be asked, facial nerve is the most common cranial nerve involved. That's usually a good guess, by the way, for multiple choice. Which of the following cranial nerves is the most common involved? Facial nerve is usually a good guess. It happens in trauma. It happens with this. Happens with Lyme's. Happens with lots of different stuff. So, and then anterior spinal roots will enhance more than the posterior ones. Don't ask me why. It sounds like something somebody would ask, but I think that's probably a little bit too obscure. All right, next case. So this is sort of a companion case, and in this one, we've got, instead of showing you enhancing nerve roots, I'm showing you nerve roots that sort of look like dreadlocks, diffusely thickened cauda really, really thick-looking spinal nerves. So when you see this, think about two things. One is CIDP, which is the reason I showed it, which is sort of like the chronic counterpart to GBS. The other thing this might be is Charcot-Marie tooth. So actually, when I saw this case at the view box, I remember thinking that this was going to be Charcot-Marie tooth, but it turned out to be CIDP. But they could look very similar. So what is CIPD? It's, like I said, the chronic sort of counterpart to GBS, has a more gradual and protracted weakness, whereas GBS is an acute thing, tends to improve within 1 or 2 months. CIPD does not. So thickened nerve roots, think CIDP or Charcot-Marie tooth. You wouldn't have to choose between those two. All right, so this is a picture from one of my books, and these are like cuts through the spine, and the triangles or the circle or the, like this thing, and this thing. This is showing you like different areas that would be T2 hyperintense and like the areas of demyelinating. So these are all the different patterns of demyelination, and you'll see that they overlap, but I sort of want to point out the classic looks. So the ones that are sort of scattered around the outside, that's sort of MS. It tends to be small, tends to be single level. And when I say level, I mean like vertebral body level, like up and down. And then the one that's like takes on the whole middle, transverse myelitis, cross-sectional ischemia, like you just had your stent graft placed that you shouldn't have had placed, neuromyelitis optica. The anterior horn is, another one that's NMO, another one that can be polio. I'd really be surprised if they showed that. This one I think is actually the one that's most likely to be asked. So if I was going to ask, and I'll show these in actual cases of them, I would ask this one. And because I think this is too easy, and I think this one's too hard, and I think this one's just right, like Goldilocks' porridge. All right, so next case, these are like actual pictures, so think back in your mind, visualize those. What do you think the one on the red is? Like the red one is, so it's just a little bit, it's off to the side. That one is MS. And then the other one, the orange one, is classic looking thing, sort of like an inverted V. So that can be two things, right? B12, which has a fancy name, subacute combined degeneration, right? Can't just call it B12. So don't expect them to call it B12 because B12 is too easy to remember. Subacute combined degeneration, they're going to use the fancy word. And then HIV, vacuolar myelopathy, can also look like that. And I wouldn't be surprised also if they didn't say HIV, they just called it vacuolar myelopathy to be sneaky too. All right, and then this is the last one that I think is the classic look. So it's the whole enchilada that's involved, like the whole cord was whited out. So ischemia is the one I always think about. Transverse myelitis too, because it's like, transverse. And then Devix, which is neuromyelitis. It's the optic nerve as well as the transverse myelitis of the cord. So transverse myelitis by itself is just a focal inflammation of the cord. Has a whole bunch of different situations where you can see it in. Post-vaccination is the classic. But you can also see it with infection, rabies, lupus, paraneoplastic syndromes, and it has to involve at least 2/3 of the cross-sectional area of the cord. And if they showed it to you in a sagittal, which I don't think they will because that's why this is tricky, you can actually have focal enlargement of the cord. It almost looks like an intramedullary tumor. And that's why they won't show it, because that, I think, would trick too many people, and then the statistics would be bad, assuming they actually run statistics on the test, which, who knows. Okay, so this is the other thing, to point out that if they are going to show you demyelinating stuff in a sagittal plane, I think that the trick to utilize is it long segment or short segment? And really the only thing to remember about this is that MS tends to be short segment, and a whole bunch of other shit tends to be long segment. So just remember the short or less. So the short one is MS. It's the common thing. So that's the common one to remember, that it tends to be over a shorter segment. Man, I don't know what I was drawing with this. This is crazy. So it's actually just from here to about here. That's probably a little bit further down. It's you're like, where is he talking about? So yes, it just this right here. But still, that's long segment, right? That's a whole bunch of vertebral body levels, whereas this is just like 1.5. So just remember, MS tends to be shorter segment, and then the other stuff tends to be longer. So if they show it in the sagittal, you can narrow your differential choices with short versus long and eliminate MS if it's long. And then if they show it in the axial plane, I would expect it's either going to be B12 or HIV with the inverted V. It's going to be transverse myelitis, or ischemia with the whole cut through the entire cord involving more than 2/3 of the cord. Or it's going to be MS. It's just like a little triangle thing off to the side, separated in space and time and all that stuff that you'd think about with MS. Pretty much no matter where you've trained, you've seen like a million MS cases because it's really common. But don't forget about it on tests, because common stuff, it's not... don't forget about common things. It's not always a trick. Sometimes it's a freebie. So, and those are the ones you definitely want to get right. Okay, so... that's going to conclude the neuro modules.